Good morning. Welcome to session 211. Am I a candidate for a non-surgical treatment option? A discussion about percutaneous alcohol ablation, radiofrequency ablation, and laser ablation. My name is Jennifer Holkem, and I'm a patient advocate for thyroid patients, educator and founder of the group Save Your Thyroid, a private Facebook community and future nonprofit organization for patients pursuing non-surgical treatment options for thyroid nodules. In 2019, I was searching for alternatives to surgery and discovered radiofrequency ablation, or RFA. And due to a severe lack of patient-oriented resources on this and other thermal ablation procedures, I created the YouTube channel It's Me Jen Again, where I share my own experience and educational videos about this topic. And I'm a passionate educator about this, an advocate for patients and doctors to save the thyroid whenever possible. Just a note, please remember that all of the information that is shared in this webinar is only for educational purposes and is in no way a substitute for consulting with your own medical professional. I'd like to take a moment to introduce our speakers today. Dr. Jules Aljammal is an American board certified endocrinologist, and he completed his fellowship in endocrinology at the University of Pittsburgh Medical Center in 2014. Thereafter, he started his own medical practice in Salt Lake City, Utah, which is completely focused on the management of thyroid and parathyroid disorders. His extensive experience in performing RFA, which he first brought to Salt Lake City in 2018, and since that time, he has performed more than 200 cases of RFA, and has published his work in the Journal of Endocrine Society. He's been invited to speak in the US and internationally about RFA ablation and the treatment of toxic thyroid nodules. Due to his passion for RFA and to advance the field of interventional endocrinology, he created the North American Society of Interventional Endocrinologists and currently serves as its first president. Next, I'd like to welcome Dr. Shahzad Ahmad. Dr. Shahzad Ahmad has performed the most number of RFA procedures as an endocrinologist in the United States. He also performed the first successful North American RFA procedure on a parathyroid tumor and the first North American RFA of a medullary thyroid cancer recurrence. Dr. Ahmad completed his residency in internal medicine at Mount Sinai School of Medicine in Englewood, New Jersey, and then went on to an endocrinology fellowship at Harbor, UCLA. His special focus is the diagnosis and medical treatment of thyroid dysfunction, nodules, and cancer. He was also an assistant professor at the University of San Francisco School of Medicine and is ECNU certified, a professional certification awarded to endocrinologists who have expertise in thyroid ultrasounds and procedures. Dr. Ahmad has performed the first radiofrequency ablation on a toxic thyroid nodule, which is a hyperfunctioning nodule, in the United States, and has been involved in trying to bring this technique to the USA for over 4 years and has extensively practiced this technique on tissue models. And he has now successfully ablated over 150 nodules or gorters without complications. And next, I would like to welcome our speaker, Dr. Iftikhar Malik. Dr. Malik is in clinical practice has been in clinical practice for many years, and in his own career had a shift when he had a thyroid problem himself. He is in Appleton, Wisconsin, and has an endocrine surgeon on his team to provide care both medically and surgically, and is a great proponent of the least invasive techniques and provides ethanol ablation and laser ablation in the office for non-malignant enlarging thyroid nodules, and he loves what he does. So just a quick note, I would like to mention that we are talking about percutaneous procedures that are done through the skin. Alcohol ablation obviously is alcohol being injected into nodules or lymph nodes, and then RFA and laser are thermal ablation procedures where the nodules are burned from the inside and the rest of the thyroid and structures in the neck are preserved. So we're just going to get right into some discussion questions about these topics. So I'd like to start with Dr. Malik. Let's talk about what steps does a provider need to follow to determine if a patient is a candidate for a non-surgical treatment option, such as biopsies, tests, imaging, etc. And how does a patient find a good non-surgical provider?
First of all, good morning, everyone, and thank you for having us. It's very great opportunity for us to present what we do and for the patients to understand the alternatives. For a patient to select a patient for proper diagnosis of thyroid cancer and see who is a good candidate for this procedure, first of all, we need to have a patient who have an ultrasound that shows high risk nodule. And if it is, there are some studies which have shown that if we follow them by active surveillance, about 78% will increase in size over a period of about 5 years. So how we follow them, select these patients is to do the ultrasound and then go for the imaging, such as CT scan of the neck, and also, if needed, the biopsy of that nodule, and selecting the proper patient for this who's a candidate. As far as how can you find a provider who can do these procedures? I think our organization, SOI, or your organization is a good resource to locate a provider who can provide these kind of providers.
And Dr. Aljammal, do you have any comments that you would like to add to that?
Absolutely. So when we think about a patient who could be candidate for treatment with ablation or chemical technique, we need patients who have first of all, benign thyroid nodules. And to confirm that, you need to do a fine needle aspiration. We like to perform 2 fine needle aspiration to give us benign cytology. And then we also need the patient to have symptoms related to those nodules. Patient who have small nodule that is asymptomatic, there's no additional benefit for treatment with radiofrequency ablation or other thermal ablation technique. Also, nodule that is toxic, that is over-secreting thyroid hormone. Those are also nodules that we can consider for treatment with radiofrequency ablation or other ablation technique. When we evaluate, we want to make sure those patients are a good candidate. And to consider that, it's not enough just to have a benign cytology. When we look at data of ultrasound showing nodule that looks suspicious on ultrasound, even benign cytology may not be enough to rule out malignancy, and those patients may not be a good candidate. That's in general when we evaluate patient for treatment with ablation technique.
I would like to add to that, and I would try to say that it is hard right now to have a very good understanding of who is the good candidate or not in the general community setting. If patients are interested, it is a little more technical, but there are guidelines that we have published as the North American Society of Interventional Endocrinology that Dr. Aljammal and me started along with some of our other colleagues. It gives you clear guidelines of who is a candidate or not. In short, what I would say is that if you feel like you might be a candidate for radiofrequency ablation, the best option is to find an endocrinologist who performs these procedures and try to get a consultation. You'll get a better idea and understanding if you're a candidate or not. In broad terms, obviously, anyone with an enlarging benign nodule, an enlarging benign symptomatic nodule could be a candidate for radiofrequency ablation, but it would require them to be evaluated by somebody who is an expert at performing these procedures. But for general public, general information, the North American Society of Interventional Endocrinology has published our own guidelines and a position statement about who is a good candidate and who is not. And I would encourage the public to definitely visit the website and have a look at those. And you know, that way you'll get more information about who's a good candidate or not.
And Dr. Aljammal, would you mind dropping the link to the NSOI website into the chat for patients to be able to take a look at that? I would appreciate that. Thank you.
Absolutely.
And so we've all kind of covered the topic of benign patients with benign nodules, but in the situation that we're dealing with today, we're talking about patients with cancer. And so I know that the boundaries for cancer patients to be treated with RFA or laser are a little bit more narrow than they are for patients with benign nodules. So would any of you like to comment on what the boundaries are for patients to be treated with RFA or
Sure.
laser for cancer?
I'd be happy to take that question. So if your question is like, who should get RFA for a newly diagnosed thyroid cancer?
Yes.
Again, remember, this is still an evolving field. So in the US, we go by certain guidelines. Obviously, guidelines are not published every year, and they take a little while to update. So currently, the standard of care is that if a thyroid cancer is diagnosed in somebody and it's less than a centimeter, and it's a papillary cancer. Remember, this is very important to understand. Only papillary cancers are what we're talking about here. If it's a papillary cancer less than a centimeter in size, the current guidelines are that if you have no high-risk features, meaning the cancer and biopsy doesn't show an aggressive type of cancer, and the ultrasound does not suggest that it's spreading outside, the current guidelines are to just observe it and don't take it out. So think about that for a minute. You can have cancer in your body, and the current guidelines are that if it's less than a centimeter, non-threatening, do not do surgery. Just observe it. Now, what happens to the cancer if you observe it? Well, the reason we observe it is because majority of the data suggests that only 2 or 3% of these grow, and only 1.5 to 2% of these metastasize. So it's very unlikely that a small cancer will do anything. However, studies have shown this causes significant anxiety in patients, and patients are not comfortable just observing something like this. So in that particular situation, then you're faced with two alternatives. Either you deal with the anxiety or do surgery. Obviously, surgery is a little too extreme for something that is so unlikely to cause you problems in the future. This is where RFA has a small little niche. Again, we don't have 10, 15 years of follow-up to see if this is as good as surgery would be for a small cancer. But we have studies which go up to between 3 and 5 years. And most of the studies show that it is non-inferior to surgery, in fact, better than surgery in terms of the overall side effect profile. But again, this is for 4 or 5 years. We don't know what's going to happen 20 years later. Is the cancer going to come back? Biggest studies and a recent meta-analysis shows that about 20% or 21% of these cancers still remain. They don't go away completely. Right? They're still there. But if you biopsy them, majority of them don't show cancer, but the nodules are still there. But up to 80% of them disappear with just one treatment session. So technically speaking, if you follow them for 5 years, it did as well as surgery did, except that 20% of those nodules were still visible. And if you biopsied them, you didn't find any cancer, only 0.4% of them would have cancer, but it was still there. So it is kind of a bridge right now, the way we understand, between observation only and the extreme option of surgery. It's kind of like in the middle, but we don't have it as part of any guidelines yet in the US that are something that you can bank on. And we don't have 10, 20 years of follow-up to see that it's going to do the same thing as surgery would do.
I would add a couple of comments there. Number one, when you're trying to select a patient for treatment of thyroid cancer, because we're talking in general about ablation here, but specifically for thyroid cancer, you want to have smaller nodules. And that's what we call microscopic, less than 10 millimeter. The larger the nodule, we do know, your chances of completely ablating that nodule will be lower. Also, location on the nodule on the ultrasound will play a major role on decision. The imaging finding, if it's on posterior aspect of the thyroid, if it is sitting in the tracheoesophageal group, those patients have a higher likelihood of recurrent laryngeal nerve involvement. Those patients may not be a good candidate. There also should be evaluation with CT scan specified for evaluation of lymphadenopathy in the neck. We do know data showing around between 30% to up to 60% of patients when they're diagnosed with thyroid cancer, they have a lymph node involvement at the diagnosis of the cancer. Those parameters need to be verified and confirmed. And also finding aspiration and finding high risk, a type of a histopathology, make it unlikely that this is a patient who will qualify. In those situations, we don't want to use a simple fine needle aspiration, but a core biopsy. So there's different parameters that you need to work on, and this is what Dr. Ahmad alluded to. You need to see a specialized physician in a endocrinology who can work up this, evaluate the patient properly to make sure this patient is the right candidate. There is data about a laser ablation, which was published in Thyroid, looked at a follow-up for up to 10 years with patient with micropapillary thyroid cancer. In this patient, only 5% had recurrence of thyroid cancer in the same thyroid gland, and those patients had surgery when they had recurrence of papillary thyroid cancer. And then those patients were followed for 5 years and no evidence of recurrence or metastatic disease was noted. So there is a long-term data of up to 10 years. Unfortunately, with thyroid cancer, one of the caveat, recurrence can happen 15 to up to 20 years. So that's when we're talking about long-term data. We're looking really for a long-term data to decide if this is good. There was recent also meta-analysis or a study looked at a cost effectiveness of active surveillance versus surgery. And this was published from South Korea. And what they found, over a period of 10 years, surgery for low-risk thyroid cancer or microscopic disease is maybe less expensive, but that could be related to their health system expenses there, which is different maybe than the United States. But there is really a lot of studies, a lot of published data, which will change our approach. I think this is, as Dr. Ahmad alluded, it's a middle situation between active surveillance and a surgery, but there's so many factors that plays a role in this decision. And the most important one is the relationship between the doctor and the patient, where that discussion decide the best course of treatment.
Another thing I would like to add to that is that even though it's not part of the guidelines, both me and Dr. Aljammal, we like to make sure that it's not a high-risk cancer. And the way we do that is if we can get mutational analysis on these nodules, it's very, very important, especially if you have a high-grade mutation. And these are, I won't bore you with the details, but something like TERT mutation or NTRK mutation or TP53 mutation or some mutations which suggest that you have a syndromic type of thyroid cancer, like a PTEN mutation or a cribriform morula. These are unusual, but still possible to find in biopsies. And they suggest that you have more syndromic, more aggressive type of cancer, which would require surgery and other type of interventions. But another thing I'd like to add is that this idea of 1 centimeter or less seems a little bit arbitrary, because there's a lot of studies which show that a 1.5 centimeter cancer probably is going to behave the same way as a 1 centimeter cancer in overall risk. So this is an evolving field. I think these parameters are still very new, and I think this is going to take some time before we have any solid recommendations about who should get this or who should not. But at this point in time, as Dr. Aljammal alluded, we're very carefully selecting patients like that. It has to be a very safe, non-threatening position of the nodule where we can actually get at it and ablate all of it. We also have to understand that patient needs to understand there's going to be long-term follow-up. We'll have to keep an eye on this and things can come back. And so there's a lot of factors to take in before you select patients willy-nilly for a thermal ablation procedure, even if it's just less than a centimeter. And do understand majority of the cancers that we diagnose in this country are small cancers when it comes to papillary thyroid cancer.
Those are all excellent points. Thank you for hitting on all of those topics for me. I was really anxious to hear about more on the genetic side. If you want to talk about that, Dr. Malik, or anyone else, if you want to comment about what are genetic profiles that are absolutely not going to be favorable for this, such as BRAF positive, and let's talk about that a little bit.
So, I mean, I'll let whoever wants to jump in, that's fine. I'll
go ahead. Please continue. You were talking already.
So again, there's no clear guidelines on who's going to do what, but we have obviously data based on the Thyroid Genomic Atlas and our experience over the last 10, 15, 20 years knowing these mutations. But if you do a biopsy, and even in cytology, without even the genetics, it comes back as a tall cell variant or a diffuse sclerosing variant or a cribriform modular variant. They already tell you that this is going to be a lot more aggressive, and there's other things, other factors that you have to take into account. So you don't, consider thermal ablation right off the bat when these types of cytological results come back. BRAF by itself in a micropapillary cancer is not enough of a reason for you to tell them like, hey, no, you definitely need surgery. But there are other high-grade mutations in combination with BRAF which would definitely do that. And it's rare for a BRAF and a TERT mutation to happen, but when that happens, obviously that's not a patient who should get thermal ablation. Other high-risk mutations like RET PTC and NTRK also tell you that you better think of something more wholesome like surgery rather than just doing focused thermal ablation. So there are some mutation factors that are very high risk, but others can be high risk in the particular context. And one mutation by itself, like BRAF, is not a reason to exclude somebody if they have a 5 millimeter cancer. So it's kind of nuanced and it has to be individualized, but certain things are big no-nos, like the high risk cytologies that I just mentioned and the high-grade mutations that we mentioned. I mean, we at our practice would not, consider those people to be candidates, and we would think that's too dangerous.
I would like a couple of comments there on this. Number one, when we talk about BRAF mutation, there's different type of BRAF mutation. Some of them are wild type, some of them are V600E, there's V601E, and they all have a different course of how this risk of cancer recurrence is there. Also, when we talk about a BRAF mutation, it's one of the few mutations that increase the likelihood of multifocality of disease. Instead of one spot, it may be multiple spots. And data show it's around 20% of those patients have that type of mutation will have multifocal disease. Also, patients who have BRAF mutation have a higher likelihood of metastatic disease to lymph node. So that make it a little bit tricky when you find BRAF mutation. The way I describe it to everyone when we think about mutation, the more you have, the higher the risk. What that means if we want to think about it, simplify, when you have one mutation, you have one drive for those cells to grow. When you have double mutation, you have more of the drive. And 1 + 1 in medicine sometimes does not equal 2. 1 + 1 may equal 10. So the multiple mutation you have, the higher risk of aggressiveness of disease. Even if final pathology report for those type of a finding may end up being benign, this is a nodule on a course of becoming something bad. This is a nodule should not stay in the neck because it's most likely with time it will become something bad. And we do have that kind of concept present in other medical conditions like medullary thyroid cancer. We do know some type specific of mutation increase risk of medullary thyroid cancer at a younger age compared to different mutation which put you in a high risk for later time to have a cancer. But we do know statistically your chances of cancer will increase with time for those. So that's the same concept. Having multiple mutation increase the likelihood of having cancer over time. And most likely this patient, this nodule should not be treated with RFA. This nodule is in a course of becoming something bad, and it's better maybe to surgically remove it. Similar to what Dr. Ahmad alluded, a couple of mutation can put you in a high risk. Combination of mutation of TB53, TERT mutation, HRAS, BRAF, and there's other type of mutation that can coexist together. Some of them allude to a syndromic situation, especially if we diagnose those patients at younger age with Dicer, one example, or PTEN. And those kind of also open more information for us about the best choice of medical treatment. There is a multi-center, studies show that patients would have multiple mutation may have more aggressive disease. And in those situations, as Dr. Ahmad mentioned, we don't choose those patients as a candidate for RFA because we do know that this may behave bad and it's better to be surgically treated.
Thank you. That was a very good explanation from both of you. Dr. Malik, do you have anything you would like to add?
I think they spoke pretty eloquently, and I don't think I have anything to add.
Well, Dr. Aljammal, my next question is for you. Is there actually a place for a combination of surgical and thermal ablation treatment for a patient with thyroid cancer?
There is a place to consider that. First of all, you can, as we've been talking before, we're deciding, is this patient a candidate for RFA from the beginning, or is this a surgical patient? But the place really presents itself after surgery for most of people. When we see a recurrence of thyroid cancer and lymph node in the neck, or see a recurrence in the thyroid bed of the cancer, which may require additional treatment. Also, that's also present itself more clearly if patient had more than one surgery on their neck, because we do know the more surgery we perform on the neck, the higher the complication rate. And even in expert surgeon hands, we do know recurrent laryngeal nerve damage go up to 6%, hypoparathyroidism increase up to 16 to 20% after second surgery in central neck compartment. So yes, there is a place for ablation technique in combination with surgery, especially after surgery when we're not talking about primary tumor treatment. But when we talk about primary tumor treatment, it's going to be one or the other. Either we're going to proceed with surgical intervention or doing an ablation technique. And I'm going to stop here because if there's the other question that will cover the subject, I will leave it to my colleague.
Does anyone else have comments on that?
So what Dr. Aljammal is saying is that we do perform this. Him and I have performed close to about 20 procedures on patients with the thyroid cancer recurrence in the neck. Some of them have been for palliative reasons because the tumor has recurred and surgeons are not comfortable going back into the same area due to previous damage and injury that happened with their first surgery. So we've been able in that situation to use RF ablation and shrink the metastasis or the recurrence in an area which is kind of sensitive that nobody else can resect. That buys us some time while we consider other treatment options, because we have new chemotherapeutic drugs that are actually very, very effective. So we've done that. But in terms of going for cure, if there's a couple of lymph nodes that recur, usually less than 3 in number, RF ablation has shown in studies, including one study that we're about to publish ourselves, to have very good results at getting rid of these cancerous lymph nodes with just one session of RFA, as long as the disease is localized and what we call micro recurrence or small volume disease in the neck. It is outpatient. It is usually just required once. If you look at the studies coming out of Korea and China, if you follow these patients for 5 years, almost 90 to 100% of these lymph nodes don't come back even after just one treatment with RF ablation. Obviously, recurrence can happen in other nodes, but it still does work as a very good bridge while we're looking at other therapies in particular situations. So we do offer that to our patients. We are routinely doing it. But again, remember, this is still an evolving field in the US because we don't have any American studies to suggest that this is safe long-term, 10, 15, 20 years. We again are taking data from other places. Our experience has only been about 4 to 5 years, and our study will have follow-up of 6 months to 12 months because that's the time frame that we've been doing this over the last couple of years. But yeah, there is a role. Definitely there is a role, to answer your question, to use both surgical and thermal ablation together in combination in some patients.
Dr. Ahmad, would you like to talk a little more about the research that you've done on this topic for recurrences? Do you have anything to add to that?
Absolutely. So, I mean, I can talk to you about our unpublished data, which obviously we're going to submit. So at 6 months, more than 50% of the lymph nodes that had cancer in them, after one session of radiofrequency ablation, were completely gone. They disappeared. The other 50% had between 70 to a 90% size reduction. The thyroglobulin number that we follow as a tumor marker dropped by about 2/3 in majority of those patients. So it does have an impact. Now, the question is, will those lymph nodes that shrunk down start to regrow again after 3 or 4 or 5 years? That's something that we don't know ourselves. But if you look at the data from Korea and China, regrowth was very uncommon. It didn't come back even at 5 years. So there is some room here to use this technique and improve the quality of life for patients who should not go for a 3rd, 4th, and 5th surgery thinking that there is no other option, because a lot of the times we did these surgeries knowing, okay, there's some cancer in the neck. We have to go get it. Why? Maybe it's going to help, maybe it's not going to help, but we do know that if we go after it, bad things might happen to the patient. So that used to be the discussion. But now we have this other option. We're still trying to figure out where this option applies perfectly. But that's an ongoing discussion that's going to continue to happen over the next few years, but at least we have an option.
I would like to add a couple of comments there. So when we talk about a metastatic disease to lymph node or recurrent in the thyroid bed, there are a little bit 2 different entities. When we talk about lymph node, a progression and mortality and a free survival, which means living without cancer, especially if you have lymph node in lateral neck, it goes around 88%. If you have a central neck recurrence of disease, survival rate may go lower. When we talk about the size of the lymph node, it also plays a role about complication and survival. The data show if you have a tumor that measures 2 centimeter, 3 centimeter of lymph node of metastatic disease, then surgery does help reducing mortality rate and improve prognosis. It's the problem when we talk about those small lymph node, the 8 millimeter, the 10 millimeter, the data is not there to show us there's a benefit of doing surgical intervention or not. When we monitor those patients, majority of those patients, up to 50 to 60% of those patients, their lymph node are stable over time. They don't change. They don't cause any issues for a few years of monitoring. Few patients, 24%, they can grow in a small percentage, 3 millimeter over time. Some will grow even more, 5 millimeter. Those are the ones that becomes most likely we need to go after. So a lot of time it becomes that question where we are monitoring those patients based on their location, based on the tumor activity, which can be evaluated by PET CT scan. Is this a hyperactive lymph node that will grow, because we know the higher metabolic activity on PET-CT, that means this tumor is active and going to continue to grow. Is it close in structure for areas that may affect the esophagus, may affect the trachea? This may be also important for us to kind of address compared to a lymph node in the lateral neck, which may not have an impact on life. So those factors plays a role in our decision making. How are we going to treat, or are we going to treat, or can we just observe those patients without any treatment? But again, here, this is a choice where we can target, where we can treat. Long-term data is not available, but in the study published in China and in South Korea, they show even after treatment, there's a small percentage, up to 2% to 5% of patients will have a recurrence of a lymph node disease in different areas in the first 5 years of monitor. So those are kind of things that maybe our study may not show, but over time it will hopefully give us more data with larger sample. The good thing from the international studies, they showed up like with Dr. Bay or with other physician who published their data, closer to 80 to 90% of those lymph node completely resolved with their treatment with ablation technique in the first 1 year, with a very small percentage, as I mentioned, for recurrence in lymph node in the neck. And over that 5 years, no one had a metastatic disease outside the neck. So hopefully more time, more data will give us more information about, is this a valid choice, especially in patients when we know complication rates significantly increase with repeated surgeries.
I'd like a small addition to that. So again, we don't actually have very good data suggesting that repeat surgery leads to longer lifespans and stuff. Mortality data is not very clear for repeat surgeries, but a very interesting recent study that Dr. Aljammal and I were discussing recently was that if you compare, if you have, let's say, 2 or 3 lymph nodes that came back in your lateral neck and you went for repeat surgery versus you did thermal ablation, and they followed patients like that for 5 years, the data was very similar at 5 years. I mean, disease recurrence rate, mortality, survival was very similar, but the big caveat was the complication and surgery was much higher compared to radiofrequency ablation. But again, that's only 5 years, as Dr. Aljammal mentioned. We do know that cancer can recur 10, 15 years later, but at 5 years, for small volume disease, like a couple of lymph nodes in the neck, repeat surgery and RFA seem pretty similar.
Dr. Malik, do you have any comments you'd like to add related to laser ablation in this situation?
There is not much study other than one mentioned by Dr. Aljammal. Most of the work is done by radiofrequency ablation. So I don't think I have anything to add.
I think in the studies that I've read, I think, or maybe not studies, but in just the literature I've read about laser ablation for thyroid cancer is that maybe the size of the probe can be used in smaller areas of the neck that might be harder to access with RFA probes. Do you have any comments on that?
Yes, it is more because of the smaller the size of the probe, you can approach the even smaller lymph node and the more sensitive areas more accurately in comparison to radiofrequency. And yeah, I would definitely say that it has a more role in those small and sensitive areas.
And my next question, Dr. Aljammal, let's talk about the difference between, I'm sorry, not the difference. Let's talk about the concept of proactively treating a sub-centimeter papillary cancer with a non-surgical treatment option versus just active surveillance.
So we are going back to the same kind of subject of treatment of micropapillary thyroid cancer. So this is where the question comes of active surveillance. When we're asking about and looking at patient and monitor those, a lot of patients end up having an anxiety if there's any change of the size of the microscopic papillary thyroid cancer, which lead to end up having surgery. And surgery with microscopic disease also comes with its own complication. So this is where maybe radiofrequency ablation or other ablation technique may play a role, where we're talking about a low risk microscopic disease that may not have any major impact on mortality or morbidity for this patient. where we can do an ablation treatment, and hopefully we can completely eliminate that tumor. And that will help patient in general. We can continue to monitor those patients. And this is where the question gonna come is it cost effective over time to monitor those patients? From my personal opinion about how we monitor patient, I think it will be, but I don't have the data or the studies to confirm that ablation technique and monitoring. Someone needs to do this study and compare cost effectiveness to say, yes, this is cost effective, and this is not really going to be more expensive than performing surgical intervention and monitoring those patients. But the data is clear, around 20 to 30% of patients, when they're having an active surveillance for microscopic disease, anxiety plays a role, and they end up having a surgical intervention at one point of time. Was that really necessary? Was that really helpful, reducing mortality and morbidity? Most likely not for morbidity, because we do know surgery comes with complication, even hemithyroidectomy. And this is maybe the role where maybe radiofrequency ablation, as I mentioned, other ablation technique can come in, fill the gap between active surveillance and a surgical intervention. And there is data there comparing a treatment with radiofrequency ablation and hemithyroidectomy. And you can see hospital stay, quality of life, complication rate, time of intervention, all those factors are all in favor of radiofrequency ablation compared to a surgical intervention. So the role is there. The question is the long-term data. And I think it's an evolving field, and the answer will become at one point of time clear for us. And I would not be surprised that in a biopsy proven core biopsy showing no high histological risk factor, low risk mutation, those patients with microscopic disease most likely going to be ablated and just be monitored. Time will prove if this is a correct theory or not, but that's why we have science. We always work harder to figure out the right answers.
I'm going to just add one small comment to that, and that is what Dr. Aljammal alluded to is the very confusing concept of cost effectiveness of radiofrequency ablation. So in European countries in Korea, RFA and surgery are within touching distance in terms of cost. It's not that much more. In the US, it's a very confusing question to answer. For example, at our center, the cost of RFA is probably about 20 to 30% of what surgery costs. But at different academic centers in the US, Stanford, Mayo Clinic, UCLA, the cost of RFA is a lot more, much closer to surgery. So the cost part and the cost effectiveness part, we cannot answer in terms of like, hey, if you have this procedure done at a big academic center, they're going to probably charge you definitely a lot more. So the cost effectiveness right now is a difficult question to answer because it's all over the place in the country. But in other countries, like in Korea and Italy, the cost structure is very different. And so you make those decisions based on the cost structure very differently in those particular environments.
I would like to add a little bit to it. I think the selection of the patient whom you're going to do the surveillance is also important. Dr. Tuttle had done a very good job at Sloan Kettering, where he categorized those patients as appropriate patient, ideal patient, or inappropriate patient. And the recurrence, the growth in those tumors, instead of 7% in Korean studies, the patient had 3.8%, only 3.8% had needed the surgery for the papillary thyroid cancer. I think in using that protocol, I think maybe the appropriate patients, category patients will be better to go for the radiofrequency ablation or the laser ablation for the microscopic papillary thyroid cancer. I think that's a very good protocol if somebody wants to look into that.
I think what I would really be excited to see is just the efficacy of proactively treating very small cancers as opposed to letting them grow to a larger size and seeing if it can actually arrest the development of any progression in the disease. So I would be excited to see if there's any data on that in the future. Dr. Ahmad, you were just talking about cost effectiveness. So let's kind of circle back to that and talk about insurance coverage for these cancers that are being treated with radiofrequency ablation.
Right. Well, it's a very difficult question to answer because it's you get a different answer in a different state and a different institution. Our experience has been not very good. It's been very hard to get insurances to approve this, even though it is cancer and it is time sensitive. There have been patients who are waiting 3 or 4 months to, hear about their appeal and, rejection and back and forth, which in my opinion is just downright unacceptable. But that's just our insurance landscape. And, I'm not going to make, any apologies for the insurance companies, but their behavior on this important new technique has been not very good at all. They have been very slow to respond to these things and to help cover patients who require this urgently. Even in palliative settings, it's been hard, but it is starting to improve. But it's a very difficult question to answer who's going to get approved or not. We have a team of people at our clinic, myself and Dr. Aljammal, who do all of this. We are writing letters, doing peer reviews, but it has been very discouraging, especially in the carriers who are national, like, bigger companies at now Blue Cross, all these companies. It's been a challenge. And so we are all working at that. Hopefully it'll become easier with time. But it is a steep mountain to climb. It's a heavy lift these days.
Have you seen a greater quantity of cancers being covered as opposed to benign RFAs?
Again, it's all over the place. It's variable. It depends on the particular insurance and all of that. Thinking logically, that should be easier. If somebody has cancer, insurance companies should say, yes, definitely do something that is, less likely to cause side effects. And it's probably less than 70% of the, or less than half the cost of what surgery would do, but that's not always been the case. So that's a difficult question to answer, but we do work at it. And we have a team of people doing that. We've had some successes and some failures, and hopefully we'll have more successes at getting this approved and less failures as time goes on and as more publications come out.
Dr. Malik, would you like to comment on that in regards to laser ablation?
My experience with laser ablation, I have done mostly the non-malignant, non-cancerous nodules, and my experience has been actually pretty decent, actually. It has been covered by insurance companies, even Medicare, and we have been pretty happy about that.
Very good. And let's actually talk about the importance of follow-up. Dr. Malik, would you talk about that, the importance of follow-up after any non-surgical treatment option?
I think we had talked about it during the session today. We don't know, which patient is going to have recurrence, and even if the biopsy, the nodule is still there. So these patients need a long-term follow-up, which include at least annual ultrasound and see if there is any evidence of recurrence. How long we have to follow this patient, I think my guess is good as anybody else, but definitely we cannot just let them leave alone and not follow them for a long period of time.
Dr. Ahmad or Dr. Aljammal, do you have any other comments on follow-up for the patients that undergo these treatments?
So it depends. Are we talking about specifically the cancer patient, or we're talking about population in general?
Ablation in general.
So when we're thinking about ablation in general, when you treat patient with benign nodule, you can still miss malignancy in around 2%. 2.24%, they still have cancer even with too benign a cytopathology. So it's important to monitor those patients to make sure you didn't miss malignancy. It's also important to monitor those patients to pick up complication. There could be some serious complication like rupture of the nodule, which can happen between 6 weeks to up to 6 months. Also other complication, including a recurrent laryngeal nerve that can happen immediately during the procedure or after the procedure. Also to make sure this is recovered and resolved over time. Most of the time, this is self-limited and it resolves spontaneously. Becoming hypothyroid after the procedure. It's extremely rare, but it can happen, especially when patients have underlying autoimmune thyroid disease. So the monitor for the first 6 months to a year is basically to pick up any major complication that can happen after the procedure. And then monitoring long-term is to make sure you didn't miss malignancy. You are monitoring to evaluate response of the medical treatment and evaluating for the possibility of regrowth. Regrowth after ablating benign thyroid nodules that are large can happen in anything between up to 5% to 20%. So all those factors plays a role about that decision making. Now, when we're talking about thyroid cancer, This is a little bit different because we're talking about monitoring of patient who is treated with thyroid cancer. So it's not different than monitoring a patient who had a recent surgery. You're monitoring those patients closely for the first 5 years. If you're defining this patient as a low risk, you're monitoring their thyroglobulin, even if it's a total thyroid gland is still present. Any major changes of thyroglobulin may make you worry about something progressing. You're looking with the ultrasound, evaluating for lymphadenopathy, making sure you're not seeing any new suspicious lymph node in the neck. So you do your workup as the patient has a diagnosis of thyroid cancer, and you monitor them as similar to how you monitor a patient with thyroid cancer. Then after the first 5 years, there's going to be a long-term follow-up with the expectation of risk of recurrence. When we're talking about small microscopic disease, estimated risk of recurrence in general is around 1 to 2%. So you're monitoring those patients in a reasonable way over time just to make sure there's no recurrence of cancer or multifocality of disease happening later in the thyroid itself. One thing I would want to mention here, which I don't think we talked about that, patient with microscopic papillary thyroid cancer diagnosed with a background of Hashimoto thyroiditis that is severely altering the way the ultrasound look may not be the best candidate for treatment with a ablation technique because you're not going to be able to evaluate the full thyroid gland properly. And autoimmune thyroid disease can be present in up to 30% of the population, which may interfere in your kind of decision making if this is a patient is a good candidate or does they have a multifocality. So I just wanted to mention that point.
Another thing about what Dr. Aljammal said is to further the point is if you ablate a tumor and after that you want to biopsy it and make sure there's no cancer in it, after RFA, it's really hard to get a good cytological sample and understand if you actually killed the tumor or not. So there are certain complications associated with micro-PTC and RF ablation that you have to keep in mind.
Wonderful. Thank you for all of those answers. Very informative. And I think now we're going to go to the questions from the audience. So I'll just start with the first. Actually, the first one's more of a comment. It says, interested in RFA for a small malignant lymph node, which is a recurrence of papillary thyroid cancer following a full thyroidectomy and radioactive iodine 5 years ago. Do any of you have comments on that?
Sure. I mean, we do this, and this is the paper that we're publishing right now. We recently published a case on that also, which, I'm sure you've seen also. Remember, me and Dr. Aljammal are pretty clear when we talk to our patient, this is not a replacement for surgery. Standard of care still in the country is a compartment neck dissection. But if the patient has small volume disease, meaning that there is no other metastatic disease, there's only 1 or 2 lymph nodes, and patient is definitely made up their mind, they don't want more surgery, then obviously we would evaluate them and confirm that indeed is the case, that they have small volume disease and 1 or 2 lymph nodes only, and patient definitely does not want surgery, and we can offer this as another option. But again, in the country and basically around the world, still surgery remains the standard of care for a compartment dissection where you take out 10, 15, or 20 lymph nodes if you feel that all of those are involved. In that situation, RFA cannot do that. But for small volume disease, a couple of nodes, 2 or 3 small sizes, Dr. Aljammal just mentioned, 1 to 2 centimeters or 1.5 centimeters or less typically, then this is an option, especially if you have already made the decision that more surgery is not for you.
I would add one comment here to Dr. Ahmad, is basically the flip coin of that, which is palliative treatment. When patients are absolutely not candidate for surgery, even if they have metastatic disease and they have a bulky disease in their neck, and the patient went through kind of discussion with the tumor board, through their case, and there's no other choice of treatment. In those situations, sometimes we consider ablative technique as a palliative treatment. So it's kind of the extreme both sides. The very, 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 very limited disease that we don't have any evidence of something else, and the very, very, very advanced disease where there is nothing else can cure it, and we're talking about palliative treatment. Those may be the situation where right now it's reasonable to consider a radiofrequency ablation.
Another thing I would like to add on the technical side, if you look at the recent case we published, it's not simple enough to just stick an antenna into the lymph node and just flip a switch and the node goes away. These nodes are close to very important vital structures in the neck. So Dr. Aljammal and I have to be very careful at advancing the antenna into the lymph node while we use another needle to inject really cold fluid to separate the critical structures like nerves and arteries away from the malignant lymph node. So it takes some time. It is a delicate and difficult procedure to do. So not every lymph node would lend itself to thermal ablation. There are certain locations where even with all our effort and skill, we cannot get to safely, and surgery might be better for those. And so there are the technical considerations before you decide, okay, I can definitely get RFA. If your node is in an area where we cannot hydrodissect or inject fluid to move it away from the critical nerve and stuff like that, then we would probably not be able to do RF ablation in those situations.
Thank you for that explanation. Next question is, what about patients who have a positive biopsy that is not amenable to surgical intervention as it is on the laryngeal nerve and are RAI resistant? Would they be considered a good candidate if it shows growth over time?
So this goes to the palliative part that Dr. Aljammal was just talking about, because surgery cannot be done. They think that it's too aggressive. If it's already involved and damaged the nerve, I'm not sure why a surgeon wouldn't want to go back and take it out, because the nerve, if the nerve is already compromised. But there are unique individual palliative situations where Dr. Aljammal and I will offer the procedure, as long as it's made in conjunction with a multidisciplinary team, including the patient's primary care doctor, the surgeon, the radiation oncologist, and the nuclear medicine physician, everyone, and medical oncologists involved. Remember, we have other therapies now available too, which are in the form of pills if you have the specific mutation blocker. There are other things we can offer. But if the whole tumor board, the whole team agrees that this is not a candidate, this patient is not a candidate for this, then yes, absolutely, we would consider that as a possible treatment target.
I would agree with the comment of Dr. Ahmad. If the nerve is compromised and is causing a paralysis and it's permanently destroyed, surgery would be a better choice, because ablation can shrink it, but will not be able to remove it. And that location is so close to the trachea. Even if you shrink it, it may continue to grow later to invade the trachea wall, and it may be better to get rid of before it becomes more aggressive. But again, this is a discussion. This is where we're talking about patient-doctor relationship.
Exactly.
Is the most important factor in the decision-making.
This is a team-based decision. I mean, everyone with different specialties has to get together, people who've been treating the patient, and make a decision together in the best interest of the patient.
Gary actually commented he wanted to answer this question. Gary, are you with us? I'm not sure if he's available to speak or not.
No, that is my answer live, so you can disregard that.
Oh, okay. Thank you. Okay. The next question is, can you please explain why this treatment is reserved for patients with papillary thyroid cancer?
Sure. So medullary thyroid cancer and follicular cancer, we don't have enough data on. Also, these are more aggressive cancers that are more amenable to distant metastatic spread. And so you're not curing somebody with the medullary thyroid cancer as consistently as you could with the micro PTC. So again, lack of data, more aggressive disease, a whole different kettle of fish. So yeah, that's not something that's being discussed right now.
And the next question is, would an MTC patient with a RET mutation who's already passed their total thyroidectomy and full neck surgery, but with tumors, largest one being 17 millimeters in the mediastinum, be a candidate for an ablation treatment of some sort?
So this would be a good question for interventional radiologists. Our approach for patient with thyroid cancer as endocrinologists focus in the neck. When there's involvement of mediastinum, this will be evaluated by a good interventional radiologist. But I suspect they do those type of treatment for a lung cancer, and they do have a indication for those situation. But I think it's beyond the scope of our question when we're dealing with thyroid cancer of the neck specifically.
And I just would like to add one comment of my own, if I may. In my particular case, now I was not a cancer patient, but I did have a portion of my benign nodule that was in the mediastinum. So it was a two treatment approach. And so the first treatment allowed the top portion to shrink and then the lower portion moved upward. However, I don't know if that would be appropriate in cancer because my nodule was much larger than a thyroid cancer that would be considered for RFA treatment.
Yeah, this is a little bit different because usually we're talking about metastatic disease that sit between the aorta and the vena cava.
Exactly.
So there's areas that is very sensitive, but there's a possibility of hydrodissection there. There's a possibility of targeting that. It's really depend on the interventional radiologist to evaluate and decide if they can approach it or not.
Exactly. Okay, great. Thank you. Next question is, I've received ethanol ablation over the past few years for tumors in the neck. Just in the past year, I've had 2 papillary tumors that would meet criteria for ethanol ablation, except for that they were subcutaneous. I was told the risk for the skin was too high, so had surgery. Would RFA possibly have been an option, or are they the same risks for the skin?
RFA is an option. Dr. Bake published a data about a thyroid cancer metastatic disease to the subcutaneous fat and treatment with a hydrodissection, and the outcome was good. There was no necrosis or burning of the skin. So it can be considered and can be done. The difference between RFA and ethanol generally can spread outside of the lymph node, causing necrosis and fibrosis and coagulation of the tissue surrounding it. It can spread out of the area of the treatment. With RFA, if you have a zone of hydrodissection and was able to do that around the tumor, you can target the tumor itself without damaging other structures surrounding the tumor. So if it's possible, and there is published data internationally. Personally, me and Dr. Ahmad, we did not have any patient who performed that treatment on. This will require evaluation, and we may look at it and we may not feel comfortable to perform it. Depends on the location, depends on the mass. Now, if it is subcutaneous, it's not difficult to surgically approach it. So this also comes a question back again to the surgeon and their expertise. Can they dissect this tumor without causing more damage, especially if it's superficial?
Another thing I'd like to add is, like, Dr. Aljammal and I have done very few ethanol for nodes since RFA has been available. Obviously, I haven't done anything subcutaneous, but if you look at the ethanol data, it requires multiple treatments of the lymph node for them to go away, compared to RFA, where one session is typically enough. So, ethanol had its role, and it probably still has its role, but it requires multiple treatments, and recurrence rates with ethanol are way higher based on the studies. Now, there's no head-to-head comparison where you take half the patients in one group and half the other group and follow them for 5 or 10 years. But the data for ethanol seems to suggest that multiple treatments are needed, and recurrence and treatment failure is a little higher than RFA. Again, it's hard to compare, it's apples versus oranges, but that's what our understanding is so far.
All right, looks like we've got just a couple more questions. This patient had a total thyroid removal 40 years ago, 2 radioactive iodine treatments. In 2003, had a modified neck dissection for recurrent disease. Recently, a 1.8 centimeter nodule was discovered, thyroglobulin of 0.7, now pending retesting. The patient has severe heart failure and surgery is not really a good option. And do any of you have comments on that?
This goes back to the palliative treatments that we have offered our other patients. If the tumor board and a multidisciplinary team of the patient's treating physicians feels that there's no other option for managing this patient, then definitely it'd be worth considering thermal ablation. Absolutely.
And we're coming up on the end of our time, so we're just going to get a couple more of these questions in. Can any of you comment on percutaneous ethanol ablation in thyroid nodules versus in lymph nodes?
Sure. So if you're talking about benign thyroid nodules, we believe in our practice, and our practice is that it has to be a complete cyst, meaning there should not be any substantial solid portions. In that situation, we prefer to use RFA because we have seen that it works really well. In terms of ethanol for malignant lymph nodes, like I mentioned, the studies show that multiple treatments are needed to make those lymph nodes go away. And the recurrence rate is a little higher based on the small amount of data that we have available. We prefer using RF ablation for malignant lymph nodes versus ethanol. And for complete cysts, obviously, ethanol is considered superior to RFA, does really well. But majority of the cystic nodules that we see in our practice, the vast majority, are complex nodules where there is still a substantial solid component, sometimes 30 to 50%, sometimes 10 to 20%, 30%. And in those situations, aspirating the fluid and ablating the solid component has had very good results in our practice. And we have some data that is going to be coming out hopefully in the next year alluding to that.
Yeah, as Dr. Ahmad mentioned, it's extremely rare to find 100% cystic nodule. Practicing for more than 8 years, I think I saw 2 cases of 100% cystic nodule. So it is extremely rare. For ethanol treatment of lymph node, they do not completely eliminate the lymph node compared to RFA and other ablation technique, mainly RFA study. They can have 80 to 90% of those lymph node completely disappear. When you do ethanol ablation, chances is volume reduction is high, but very minimal number of those lymph node completely disappear. And then when you do ethanol ablation, there is also a possibility, or when you do the technique itself, you're trying to hit different spot of that lymph node and injecting a very small volume. Generally, when you do ethanol, pain level is between mild to moderate. People, even with injecting a lidocaine around the lymph node, still complain of pain and discomfort related to the ethanol injection. As I mentioned, when you inject a nodule, solid nodule, or hyperfunctioning thyroid nodule, a success rate of ethanol ablation is really low, and they require multiple treatment. Compared to RFA, example, a toxic nodule, one treatment for nodule that are small, 10 cc or smaller, 10 to 12, success rate is a significantly high, 90 to up to 100% of those nodule, one treatment will fix the hyperfunctioning nodule. And then the last thing to mention is the ethanol can spread outside the area, causing fibrosis around the tissue surrounding that nodule. And we've seen a couple of cases where we see a infiltration around the thyroid gland, which make it more difficult to treat, maybe even later with surgery. Not published in literature, but we've seen clinical practice, a couple of cases like that.
Great. Looks like we're going to be running out of time here in about 5 minutes. I'm going to take 2 more questions. It looks like we've got one question about palliative, actually 2 questions about palliative care, where a patient has a surgeon who will not remove a tumor due to risks, and improving if this is a treatment that can improve the quality of life through the procedure, even though it doesn't offer a cure. So I think we've already kind of talked about that.
Absolutely.
Do you have any more comments about palliative care as opposed to risks of subsequent surgeries?
Absolutely. This is what we signed up for. This is when we went to medical school, because we want to improve people's quality of life. We know we're not always going to win. We cannot have 100% cures of these tumors. We've accepted that as physicians with experience, but we still want to do our best to improve quality of life for patients. And if this is the only option available, or there's no other better option available, we would obviously do our best to be able to provide that for our patients. And that's what part of our society mission is for interventional endocrinology, to be able to spread this all across the country so people have access to it, whichever state or city they live in. But in the meantime, absolutely, if that is the situation, we would do our best to see if the patient is the right candidate and offer this.
Wonderful. The last question I'm going to address is, can RFA or laser be performed on a papillary cancer located on the isthmus?
Yes, it can,
Mm-hmm.
but isthmus nodule are a little bit tricky. So the data show if you have an isthmus thyroid nodule with malignancy, they have a higher likelihood of spreading, especially if they're larger than 8 millimeter.
Mm-hmm.
And then the second component is always going to be, is the ablation zone is safe? When you have a isthmus that generally measure around 2 to 3 millimeter, and you have a nodule in that isthmus that measure 6 millimeter to 7 millimeter, this nodule is pushing on the capsule of the thyroid gland. Is there a sign of extension? Can I ablate this area without damaging the trachea? Can I approach without increasing complication? If I can hydrodissect, if I can create a safe zone, it's quite possible I can ablate. But if the isthmus look or it's impossible to hydrodissect, it looks like it's extending outside the capsule, then the chances of ablating that nodule successfully it become lower. So it's more technically challenging, but not impossible. But it also depends on the experience of the physician, the evaluation, if there's evidence of extension, if there's evidence of lymph node involvement, then this is most likely not going to be a nodule that will be treated. I think that's kind of what plays the major role when we're talking about isthmus nodule. And a lot of time when you see isthmus nodule, they lean to one side or the other. Rarely you can see them just in the middle itself. It's most of the time extend to part of one of those lobes on the right or the left.
Thank you. I would like to thank everyone for attending this session today. We need to close this off. So Thank you, doctors, for all of your expertise that you've shared with us today. I would like to invite all of the attendees to visit nasoie.org. Is it .org?
.com.
.com. Okay, nasoie.com for the NASOI website, and also Save Your Thyroid in the Facebook community. We do have a list of providers who offer non-surgical treatment options for thyroid nodules, cysts, and cancer. So with that, we will say goodbye. Thank you all so much for joining us, and have a lovely rest of the conference. Take care.
Bye-bye.